record this. There it is. Good evening, everyone. Welcome to the FSHP Town Hall Special Edition Legislation Update. I am here tonight as your president, Kathy Baldwin, to introduce our special guest speakers. Kyle, if you'd like to pop up in here, we can see you. This is Kyle Robb from ASHP. Do you want to tell us your title there, Kyle?
Hi, everybody. Hi, Kathy. Thanks. I'm Kyle Robb. I'm the Director of State Policy and Advocacy at ASHP.
And thank you for being here tonight. Kyle is definitely an expert. We have Ken Comey from Moffitt Cancer Center, who is a, well, I'll let you introduce yourself, Ken, and I want to thank Ken because he went to Tallahassee and he brought this message to the legislators and they heard him. So Ken, if you want to pop on up there and say hello to everybody and give us your title.
Yeah, of course. Ken Comey, Vice President and Chief Pharmacy Officer at Moffitt Cancer Center. It was my honor to go up to Tallahassee and testify and kind of share some of the stories. Kathy, you did a fantastic job as well in your testimony up there. So that was a big part of, I think, of that approval process.
Thank you, Ken. And last but not least, our current treasurer, Dave Lacknow. If you want to jump in here and say hi, Dave, and give us your title, please.
Yes, ma'am. Hey guys, Dave Lacknow here, Executive Director of Pharmacy Services at Broward Health in Fort Lauderdale, Florida. I appreciate the opportunity to join this group of folks today.
Thank you, Dave, for being here. Ken, if you'll do me a favor and scroll down to one or two slides. Tamika is going to jump on here. If you'll go back one slide and just talk to us about the annual meeting.
It's all the way at the end. Sorry.
No, that's okay. Just stay on the agenda. It's fine. We're going to circle back to it.
All right. Hello, everyone. Tamika Bennett, Operations Director. Thank you guys for joining us this afternoon and bearing with us as we have a few technical difficulties in the beginning, but we are ready to get started. Today is May 31st. It has been extremely exciting here in the office because it is the last day to get your early bird discount for the annual meeting. So if that light just went off, go ahead. We're not going to be mad if you kind of jump over to another screen and register for the meeting because tomorrow that discount is gone. So please encourage colleagues. You have until 11:59 to get that registration in. We are excited. This is shaping up to be a very epic meeting at the Gaylord Palm. So we are excited and we're looking forward to seeing you all there. Thank you so much.
And that's our very lovely Tamika Bennett. Thank you, Tamika. If you could put in the chat the link, I think that our registrants would be appreciative of that. And with that, I will step aside and let the experts have at it. Ken, I think, or Kyle, I think I'm turfing to you. Dave, correct me if I'm wrong, please.
Yeah. So Ken, do you want me to open it up? You're muted, Ken. So guys,
I think Kyle's going to lead off, and then
okay.
We get it to Bill. I think you can kind of take the reins from there. Yeah.
Perfect.
All right. Hi, everybody. So I'm just going to start off with some general background information for people who might not be as familiar with white bagging or the terminology of it, and give a little bit of background on the national landscape of this. So generally speaking, most people on this call have probably already heard of white bagging, but just in case you haven't, we wanted to make a point of defining it just so, you know, we don't have anybody who's totally lost in the conversation we're having here. So white bagging is primarily a payer-driven activity, meaning that it's tied to coverage and reimbursement, wherein a clinician-administered drug, meaning a non-self-administrable drug, which we'll get into in a little bit, is shipped from a mail order pharmacy directly to the location where it is administered, in contrast to so-called buy and bill or the traditional purchasing process. So if you think of a hospital outpatient department that provides infusions, the typical acquisition process would just be to purchase drug in bulk from the wholesaler, prepare it as necessary, and then administer it according to orders from the physician. In a white bagging bottle, the insurer says we are not going to pay you or reimburse you for any drugs that you purchase and administer to people. The only way that you can get covered drugs from this plan is to send a prescription to a mail order pharmacy, and then we will send you an individual patient-specific prescription for the individual dose the patient's going to get. So think an individual FedEx package or UPS package containing one patient's dose for one round of an infusion. That is white bagging. Similarly, there's another term out there called brown bagging. Brown bagging is when a non-self-administrable drug is given directly to the custody of the patient. So either a patient picking up at a pharmacy or mailing directly to a patient. Think a patient having to have vials or an IV bag in their home refrigerator next to their food and beverage, and then having to take that out of the refrigerator, put it in their car, and then drive it to the clinic appointment for administration. That is brown bagging. And again, these are primarily payer-driven activities. So if we go to the next slide, another important thing to keep in mind when we're talking about white bagging is this applies to clinician administered drugs, right? So we're not talking about self-administered drugs. If those drugs, like, otherwise we would just be talking about mail order pharmacy. And when explaining white bagging to people say, how is this different from mail order pharmacy? The difference is that these are non-self-administrable drugs that require significant amounts of manipulation, reconstitution, or compounding before they're administrable to the patient. So a key component of white bagging legislation and getting policymakers to understand white bagging is to really create a statutory definition for clinician administered drugs to really separate them from self-administrable drugs. So we have the definition on the slide here, but as I mentioned, this is just a drug that cannot be reasonably self-administered by the patient to whom it's prescribed. Most often we're talking about infused drugs here, but the term could also apply to certain injectable drugs or implantable drugs too as well. You might also hear people refer to physician-administered drugs or provider-administered drugs. That's the same thing, different terminology for the same concept. Next slide. So this is the map of where we're at with states that are attempting to address white bagging through legislation. So one really important thing to note here is that actually we've been tracking this for several years. And as far as we know, the first piece of legislation targeted at payer mandated white bagging wasn't introduced until 2020. So this is very recent efforts to legislate this. So as you can see, we've had legislation introduced in a majority of states, and we're now up to, depending on how you count, up to 13 states that have passed legislation around this. In the early days of white bagging, so the thing about white bagging, right, is it creates operational strain. It confuses patients. It causes more copays. It delays treatment. Basically, it is a downgrade in the quality of care. There are obviously reimbursement implications. It's a downgrade in the quality of care and healthcare operations for everybody except for the payer. Some of the earliest attempts to regulate white bagging or try to tamp down the practice focused on pharmacy practice perspective, saying, the pharmacies can't be sending it, or pharmacists making it a violation of pharmacy practice, basically to engage in white or brown bagging. We at ASHP don't endorse that because really, as I mentioned, this is a payer-driven practice. And if you make it a pharmacy practice violation to engage in white bagging, well, then you're only punishing pharmacies and pharmacists rather than the payers that are actually driving the activity. So early stages of white bagging was really looked at from the pharmacy practice lens, but in recent years, we have shifted that to really be focusing on the payer aspect, because a lot of people might be familiar with the concepts of white or brown bagging in the context of a limited distribution drug, where this is a one-off, a very unusual circumstance where you can't get this drug through your normal channels. Maybe there's a shortage or something going on. And this is sort of a one-off, backdoor thing to get the patient the medication. But we're now seeing insurers flip that and make that sort of the primary way and the only way that you're able to acquire drugs. So the way that we address this through policy is really looking at the payer, the insurer, the PBM, and saying that you can't mandate this form of a distribution as a condition of your coverage. So the first time that laws like that really popped up were in 2020. ASHP, we published model legislation on this in early 2021, and we've been trying to shop it around the states, and we've seen a lot of activity around it, even to the point where we now have 13 states that have laws addressing this. Now, I will say that all 13 states, all the laws out there that have been passed are not created equal. Some of them simply just try to add more definitions or standards to specialty pharmacy accreditation to get some of these plans to open up their specialty pharmacy networks to make it more difficult for them to route all of these drugs through one preferred mail order pharmacy. But other states have really gone further and explicitly trying to address this, making that the purpose of the law, and really doing what they can to sort of prevent payers from engaging in this. And I am happy to announce Florida Senate Bill 1550 that passed earlier this month is actually among the best laws in the entire nation in terms of its comprehensiveness in addressing this. And I'll let Ken and Dave sort of get into the finer details on that, but that was a bit of national background for everybody. So I think I'll pass it on to Ken now, if that's correct.
I think Dave's going to take the section.
Sure. So guys, we're gonna kind of preface everything, right? The bill was just signed, probably going to take effect in July, and then we start the process. As we go through this presentation, as we read sections of the bill, we focus specifically on areas that we think directly impact the practice of white bagging, as Kyle described earlier. Later in the presentation, Ken is also going to talk about the system strategies on how to manage the interpretation of this language. So I think everything we present is our interpretation of as we see it in our health system, and how we are interpreting the words in the language, and then later you'll find out about strategy. So first of all, guys, Senate Bill 1515 is a 49-page bill. If you went on, clicked on it, printed it, so it's a lot of language. What we focused on were the sections that we think are specifically white bagging. I think the first section of the bill, it talks about who's included to be contracted with in this space, and they really break it down into several sections: essential providers, cancer centers of excellence, organ transplant hospitals, specialty children's hospital, and regional perinatal intensive care center. To keep it at a very high level, each of these are state specified criteria, and there are lists within the state of health systems that are usually in these areas. Not all of them, but I know some of them, there are lists. So such providers can contract, must be solely for the and I love this language, administration or dispensing of covered prescription drugs. So that means administration, as Kyle alluded to, is that you need a clinician to administer the drug, but we were able to keep the word dispensing in there. And Ken, I'm going to credit you for that. I think keeping the word dispensing in there, and I'm going to put a crown on his head for this one, because that means those all those drugs that maybe it's a self-administered drug to the patient is included in this too, that healthcare system can also continue to provide. And that was a word that was trying to be removed at some point, and I think the health systems spoke up and understood and communicated how important that was to keep that word in there. So they need to provide. So again, the first section is who's included, and the second section is contracts provided for administration and dispensing of covered prescription drugs, including biological products that are administered through infusions, IV injected, inhaled during surgical procedure, or covered parenteral drugs as part of on-site patient care. And as you can imagine, it's a lot of that self-administration infusion type products that we're giving in our health systems that we're providing the care for. Next slide. This is so this section, and if you looked at the bill, I always like to go for the specificity of the line, 825 to 837. If you look at the and we're going to read it in a minute, but if you look at the legal, or if you look at how specific they are here, it's kind of how the PBMs steer business away from you and into the white bagging practice. So the language here doesn't use the word white bagging, but if you look at the way the language is scripted, it really says, hey, don't do these things because it looks, feels, and it's shaped as the definition of white bagging, as Kyle alluded to earlier. So you do not require a covered person to receive a prescription drug by United States mail, common carrier, a local courier, third-party company or delivery service, or pharmacy direct delivery, unless the prescription drug cannot be acquired at any of the retail pharmacy in the pharmacy benefit managers network for a covered person pharmacy program or development. On the slide before, I said if you met one of those inclusion criteria, you should be contracted with. And on this slide, to me, it says, my interpretation, it's the patient's choice. So if the patient chooses to use your health system pharmacy who is contracted, the PBM can't steer by moving into any of these areas. And the second part of this language, I'll lean into that a little bit. This subparagraph doesn't prohibit the pharmacy benefit manager from operating a mail order, so they can provide the service or delivery program on an opt-in basis, so they can tell the patient to opt in at the sole discretion of the covered person. So that means that the patient has a choice. So as you're communicating to the patient, I think important to let the patient know that they have a choice in who they use in the pharmacy, and that you are an in-network pharmacy and you can provide that service. And I think those are the phone calls that we're going to see happening when this thing goes live. As we continue down the language of this section, provided that the covered person is not penalized, so you cannot penalize the patients for imposition of any additional retail cost sharing obligations or lower allowed quantity limits for choosing not to select the mail order. To me, that means you can't say to the patient, by the way, you can get a 90-day from my mail order at a lower cost, and the 30-day in the pharmacy may not be there. I've seen PBMs basically position quantities as an incentive to get the patient to use the mail order. Hey, I'll give you a 90-day supply and you're good for 90 days, whereas we're not going to approve 90-day in the contract pharmacy. To me, that kind of puts the card on the table that levels the playing field in that process. So again, I think what I covered in the first two slides is who's included and the language that really speaks about white bagging. Next slide, please. All right, I am going to hand off to Ken on the next set of slides. He's got a lot of detail as to some specificity in these provisions, and he's going to cover that with you so you can see what the specificity interpretations are from his view.
Very good. Thanks, Dave. So I'll refer back to the slide Dave talked about that highlighted on 1550 that it requires a pharmacy benefit manager to offer a provider contract to licensed pharmacies physically located on the physical site that providers are located. This really speaks to the fact that pharmacies have to be involved with this level of care. So physician offices, non infusion centers that are independent are not subject to these protections through white bagging. And as Dave went through the different criteria, the first was essential providers. This is the Florida statute that refers to what an essential provider is. So an FQHC, a teaching hospital, trauma centers, hospitals located at least 25 miles from other hospitals. This is language that your hospital, different departments are going to be aware of to know whether you qualify or don't qualify. Also important in this is that this speaks to Medicaid definitions of essential providers, which allows inclusion of those patients into these discussions. I think that's relevant. We're not going to get into the depth, but this is a statute that you're going to want to check into. And then the second group were Cancer Centers of Excellence. Here's a statute that refers to those organizations that have received that designation as a Cancer Center of Excellence. So I'm going to move on now, but I do want to spend just a moment to share how monumental this is. I know Kyle kind of touched on this a little bit, the fact that we have one of the most robust laws in the country right now around white bagging. This was a bill that was unanimously approved by the House and unanimously approved by the Senate. So it had bipartisan support. It was, being a part of that process and kind of getting in and watching a lot of the different hearings. It was very clear that the legislators are very interested in reforming PBMs, and not only on the community retail side, but on the injectable side and the white bagging, brown bagging, site of care steerage aspects as well. And we'll talk a little bit more about that. But what I wanted to share with you is some of the data that I shared under testimony at the Senate, and that's some data that we've collected around our experience with payer mandated site of care steerage policies. Back in December of 2020, we had a payer that mandated our patients be steered away from Moffitt Cancer Center. Since we still had access to those patients and they were still our patients, we were able to collect some data around the practices. And we looked at several key performance indicators, including medication shipping timeliness, including patient treatment delays, touch points throughout the process, and then the patient's fitness for redirection. We also made observations around patient complications, as well as the financial impact to the patient. In all, we had 212 patients that were impacted, and so that was our sample size. When we looked at the data, overall, 48.6% of the time, doses that were sent from these out-of-state specialty pharmacies were sent appropriately. About a quarter of those patients, the drug was sent more than a week before the dose was due, with one dose being sent 41 days before the dose was due. And as a part of the white bagging, brown bagging work group that met over the last 2 years, it was very clear from the Board of Pharmacy that patients should not be storing their injectable cancer drugs at home in their kitchen refrigerators for more than a week. And so again, that was 25% of the patients. But more concerning was 6.5% of the patients that were dispensed from that out-of-state specialty pharmacy after the dose was due. This included pegfilgrastim that was 42 days late, lanreotide that was 39 days late. And so when you added all, even the ones that were shipped within a day or two, overall, 11.4% of the patients, or 1 in 8 patients, had a delayed or missed dose as a result of these delayed drug deliveries. And when we looked at some of the outcomes that these patients had, significant negative outcomes. We had several patients whose pegfilgrastim was late. They developed neutropenic fever, required hospitalization and antibiotics. We had patients that were late getting their treatment doses and had progression of their cancer to stage 4 cancer. And so it was significant. And I know that these are some of the same reports that we've heard through that white bagging, brown bagging group and through FSHP's collection of data cases across the entire state. So every corner of the state, we have these same examples. So it's not something unique or different with Moffitt. It's establishing that pattern. We looked at touch points, and a touch point is a communication between the provider and the insurer, the specialty pharmacy, or the PBM. On average, there were 10 touch points, so an email, a phone call, but it was as many as 30 touch points on a specific issue or a specific dose. And when we drilled down into those patients, 53.3% were unfit for redirection, which included about 50% of the patients were stage 4 cancer patients. So we have patients that are in their last weeks to months of life, and they're jumping through up to 30 hoops in order just to get the medications that they need. Again, relates to some of the delays that we talk about. We also looked at, although not formally, we looked at, we collected some of the data around finances for the patients, and they're taking a hit on this. Several patients reported out-of-pocket expenses that were thousands of dollars higher than when they were getting care before. These patients were serving as their own controls because they had been treated at Moffitt Cancer Center. What we've learned as well is that as they were transitioned to other sites of care or to other pharmacies for their care, some of those places would not dispense the drug until they received the full payment up front. So some of the delays included the fact that they weren't willing to dispense drugs until they were assured they were getting paid from that perspective. So what we've done here, I'm going to pivot to the next slide, is we have published this data. This data is in AJHP. It's on the online version right now. We worked with Kyle and David Chen from ASHP. This is something that is very important to ASHP, one of their primary advocacy initiatives they have going on. And so they were instrumental in helping with the publication of this. We feel it's really important to have this information in a peer-reviewed journal as we're talking with legislators to say that this has been vetted through. This isn't anecdotes. It's gone through a rigorous process to be put into the general publication. And I think that's part of, I'll just pause there before we get to the next slide, Kyle. I don't know if you want to add anything. I know you and David are very interested in having some of this data collected and shared across the country.
I just want to, give kudos to you again, Ken, for really leading this and being the primary author on this and data collection, because this was extremely useful in Florida. And I can also say we've already submitted as testimony in at least one more state. that's Rhode Island, that had a white bagging bill, and they actually, the Senate actually just passed that today. So it got through a chamber. So yeah, this has been extremely useful information and sort of helpful for white bagging, because one of the big things we encounter, when we're going through this advocacy push and we're fighting with the payers over this is we don't have a shared reality here. They are very much 100% of the case of white bagging is great. Nobody minds it. Doesn't degrade quality of care one bit. And show us the bodies, to be, to use a bit of a morbid phrase. So it is really, really necessary for us to collect detailed quantitative data to really show the impacts of these types of policies on patients. So thanks again, Ken, for leading that.
Yeah, of course. And I put in the chat, I did an interview with FSHP talking a little bit about this and some of the work that's been done in Minnesota. Minnesota's been very active in this space as well. So for your reading pleasure, that's in the chat. But we'll move on to really where do we go from here, right? So it's fantastic that we've been able to get such a robust bill passed, and it's going to become law on July 1st. But there should be no misperception. The work is not over from this perspective. It's getting ready to get really heavy lifting because now we need to, this is something again that affects many of us, and we need to see these changes, but we need to be in control. We need to take the offense on this to make these changes occur. If we sit back and say, well, we're just going to wait and see how this happens and hopefully everything works out, it will not work out well. So the first step from my perspective is, well, what have we learned from other states, and what have other groups done in this space? To go back to what Kyle was talking about in the map he shared, we're state, I think we were number 10 or 11 that passed this. As Representative Cheney and Senator Bordeaux, who were the two sponsors for the House and the Senate bill respectively, as they crafted this bill, they took into account a lot of the laws in the other states that have already occurred and said, okay, what have we seen in those states, and what loopholes have the PBMs and insurers jumped through, such that we can tie those loopholes off and we can make this a more robust bill. So they did a great job in moving that forward. But let me highlight some of the things that I've learned as I've met with people from different states that have passed these bills already. They love to, the insurers, PBMs love to slow play this and provide denials to applications. So I talked to somebody in one state that was up in the Northeast, and as pharmacy was filling out the enrollment form, again, the contract to be able to provide services for their patients, there was a section that they didn't have all of the information on. And so they tried to clarify with the PBM of, okay, what are you specifically looking for and what data do we need to collect? And they said, oh, you got enough on there. Just go ahead and turn it in and we'll sort all that stuff out. So they submitted the form, went forward with it, and after several months got a denial letter from them saying that the form was incomplete. It took that pharmacy a year to be able to provide services to their patients. And so that slow play of taking their time is something that is part of the playbook, I guess. PBM trolling, as I spoke with another representative she was from Louisiana, which of course has approved legislation. She talked about this PBM trolling, and I said, well, what is that? And she said, well, you have to believe right now that the PBMs are reaching out to their patients that they have steered away and sharing with them that they need to stay within that PBM network, that they need to, and she said, they'll say all kind of things. They'll say to the patients, your providers are recommending or suggesting that you stay with us. They have attempts to bribe them with incentives and gifts and things like that. And so it's important, and I think Dave mentioned this, that we reach out to our patients that have been impacted to let them know that we have the ability to provide services for them. And make sure that we are being aggressive with that. We're going on offense and we're communicating with our patients. The incentives and gifts, as Dave mentioned, there were a lot of amendments that tried to get fired in there. And actually this one did get in. They carved off all of the prohibition of incentives and gifts that PBMs can provide to patients. It got pulled out of the amendment got approved. It got pulled out of the House bill. But when they got reconciled, the House and the Senate bill, they left the Senate version, which included all those prohibitions. So again, as I said, I think our sponsors for the House and the Senate bill, they were very savvy as they were crafting this to make sure that a lot of the lessons that they learned in other states are part of that legislation. So we're getting to the point now where we're pivoting from the legislation to law to practice change. And as I said, we need to be proactive as we're providing for our patients. So the last slide, and then we'll stop and open it up for questions. Next steps for here in Florida, and this is what Moffitt's approach is. It's something that we've been working on. There certainly are others, and if people want to kind of speak up, I'd be very interested to hear what other approaches are. But this bill becomes law on July 1st, so we have one more month before this becomes effective, and we're able to influence this change. We've been working very closely at Moffitt. The managed care payer strategies and the legal teams have been working very close together, analyzing this law, analyzing our insurance code and our contracts, and we've been actually we've contracted with third-party consultants, both on the managed care and on the legal side, to kind of assure that we're understanding this correctly. The first step in this is to assess which of your patients have been steered away. And that's what we're doing. We're looking at patients that have been steered away and getting information about them. And the vast majority of the data that I presented is from one insurer with a Florida policy. So all of those patients are going to be qualifying for that. But we do have patients that have out-of-state plans, and those plans may not qualify within Florida from a Florida law perspective. But the next step, so once we identify the patients, we are sending certified letters to those PBMs and insurers requesting the ability to provide services effective July 1 as mandated by this law. We're also including in that language 30-day turnaround time that we require action to this letter within 30 days. We don't get a response to that letter. We're going to send a second letter and a third letter, which will highlight some of the missed opportunities, missed deadlines, so that as we're able to move forward with this, if we're having issues or we're seeing problems with the insurers or the PBMs following this law, we want to have a situation in which we can document that. We have a paper trail, and we're able to provide that to the legislative channels to be able to influence change. We're going to negotiate with the PBMs and the insurers and the contract if it's unfair. If it's a lowball offer, our legal consultant said that is 100% against the spirit of this law, and it is something that the legislators would probably take offense to. So again, keeping track of that sort of information. What else can I add to this? We're keeping a close timeline, as I said, of all the communications. That when we get to a point of, if we do see obstructions or we do see barriers that are provided by the PBMs and by the insurers, we're going to report that to the appropriate governmental agencies. And I think as you look at 1550, the reporting for the complaint filing structure is to the Division of the Consumer Services of the Department of Financial Services in the Office of Insurance Regulation. So having all that stuff together to be able to file that complaint. And I think it's going to be super important. Kathy Baldwin was able to do an interview along with Representative Cheney in a New York Times article, which, Kathy, I'll put you on the spot in a second. I'm not sure when that's going to be published, but the feedback Kathy shared is that if there's any roadblocks and these complaints are filed, that they'll take action on that, and that it's certainly within the scope that it could be a possible path to litigation if there's significant pushback. And I'll just pause there, Kathy, to see if you have anything to add.
I'll just mention one thing, and then maybe Diane Jones had a couple of questions, so maybe we could tackle those. And if you have questions, maybe put them in the chat. That'll help us. So yeah, it was interesting. Claudia Devant, who is the FPA lobbyist, said that Alexandria, she goes by Alex Glorioso, was interested in the cases that we presented to the legislators. So about a couple years ago, I guess, Andrea Ledford said, we need to be collecting these stories. So Kevin, our employee, built a webpage for us to collect these stories. So we compiled these stories. And Ken, I think when you present it to the Senate on 1550, you had a Moffitt cancer patient there, and she didn't do well with the traveling. Is that what happened?
She didn't do well with the traveling after that. After that.
Yeah, it
testimony.
really took a couple days for her to recover. So
Yeah.
we knew that we needed to take patient cases forward with us. The legislators told us that in legislative days in 2022. But it's unfair to ask these patients to come forward because they're sick. And, it took this patient, Ken's patient, 3 days to recover from that, as I recall.
Yep.
So we kind of knew that we needed to be their voice and take these patients forward. So we had a transplant patient from Miami who didn't get their drugs. And as a consequence of that, they lost their liver and they had to go back on the UNOS list. Many same cancer stories. So when I presented these stories, Claudia said there was a journalist from the New York Times. She does freelance writing, named Alex Glorioso. And if you Google her, you find that she's a cancer survivor. And she was one of your patients, Ken. And she received in the mail her filgrastim, but she didn't know it was coming. So she missed the whole dose because they never communicated with her that she would be getting this in the mail. So she is now a founder of Bard Owl Press, health reporter, and she is trying to educate the public on PBMs and all this nonsense that cancer patients have to go through. It's bad enough you have cancer, but then you have to deal with all this on top of that. So when Representative Cheney was there, she was talking about the strategies to ensure that PBMs comply with this legislation, including reporting, which I think you mentioned. So if it's okay with you, Ken, can I go to Diane Jones from Mayo Clinic? And she asked, can payers restrict the contracting language to only the diagnosis is included? And that would be cancer, transplant, pediatrics, relative to white bagging. And that may go to Kyle or to Ken or Dave. I don't know who.
So guys, if you want, I can, when I read that language, and again, it's all interpretation, I think anything is possible in the strategy that they're going to use to interpret the language. I didn't see that as a first thing that I think they would go after. I think the language of who's included doesn't say you limit it to that patient population. So I believe that you would have a very strong argument that if you meet the qualification, your pharmacies are contracted to take care of all providers that are receiving those medications. But again, I think that each payer, and it wouldn't surprise me if a payer tried to, but I think you would have a strong argument against the limitation and going after to contract with my pharmacy for all of my patients that I take care of in that setting. So I'm expecting so I think a lot of these answers, and I read through a few of the question, I think it depends. And I think it depends on the payer and how much they want to, as Ken talked about earlier, how much do they kind of want to slow this process down? I think some will take a strategy of trying to slow it down as much as they can, and that's one way. I think others are just reading it and saying, okay, we'll contract with you. I won't say who, but I had a payer who a month ago said, no, absolutely not. And then last week they said, yeah, we'll sign a contract with you. And I think simply because the bill got signed and they're probably doing the review. So I do think that the bill being signed, I think you have some payers that are just now going to start working through the process, but I do think you're going to have, and I think we've seen patterns of, you're also going to have other payers that are going to try to push the envelope a little bit. Long answer to your question, I think, but for my interpretation, I think we're going to see a little bit of everything in this process. Ken,
Dave, I think what I'd like to do, if you don't mind, is I'd like to make a disclaimer here that we are not lawyers and that it's very important that you work with legal counsel within your health systems. And the other thing that I would ask is, I know Ken and Dave, you have been talking with your lawyers at the hospital. So if you have anything to add from what they've told you, we would appreciate it, but please don't, FSHP is not liable for this. I have to put that disclaimer out here.
Yeah, and Ken Comorny is not liable either. This is Ken
And
Comorny's
then the
opinion,
other
and that's
piece to
all.
that is, if
all it
you start
represents.
to have problems, we want to know about it because we can help you.
Yeah, that's
So,
right.
you know, we still have that webpage, but an email off to Tamika saying, you know, we were refused this, we can get that to the right people. And also the board told us that if there are pharmacists who are being barriers, they can be written up in the Department of Health as a complaint. So I'm not just saying pharmacists, I'm saying all healthcare providers, but again, please, this does not substitute your legal counsel in your own health systems.
Yeah.
But Diane, I know you had another question as a follow-up. Bill becomes law July 1st, but it specifies it applies to benefits on 1/1/24. Do you expect to influence change on 7/1?
I was just gonna add to what Dave said
Oh,
on the first
sorry.
question that Diane had. I don't see anything in the bill that talks about being able to restrict based on diagnoses. I mean, I didn't control F the document to see if diagnoses was listed in there. But, you know, if it's not in that law, then they can, I mean, and I'm sure we should expect they're gonna come up with all kind of crazy stuff. But if it's not in that bill, then that doesn't mean that they can do it, right? And I think, as Kathy said, it's important that when you get these questions, that, so Diane, I don't know if you've gotten this question already, but would be to huddle up with your legal team and say, okay, I'm not seeing this in there. Can you help me? Is there something, how this could be interpreted to include that they can contract based on diagnoses? And if not, I would challenge them on it, right? Just because they provide that and say, oh, well, this is what we think is right, doesn't mean that it is right. And you should challenge them when you see those type of things. On the second question, that's a great question. And that may be an answer that you get from the payer or the PBM, is that they can't do it because of this reason or that reason. And same thing, you need to kind of sort through and vet through to make sure with your legal team that's okay or that's acceptable. I think this is this question highlights though something, a point that I wanted to make, which I kind of talked a little bit about. As we prepare for legislation 2024, which I expect we will see a further revision of this bill or further fine tuning of this bill. The legislators were very clear. This was the start, not the end of what they want to accomplish with PBM reform and around white bagging. Is we need to flip over as many rocks as we can in this process so that we can give that to the legislators to say, okay, here's what we learned. When this went law, you guys thought this was going to happen on July 1st. Their policies are making this so that it really doesn't happen for 6 months. And provide that information to them. So as they craft that next legislation, they know, oh, we got to include this because this was one of the tactics that was played.
Just to add on a comment, you know, to what Ken was saying about the implementation date, you know, they may not necessarily have to make any changes prior to January 1st, 2024. But in the interest of being proactive, I would recommend reaching out to them and starting those conversations early, because their response to your initial inquiries might inform whether or not this particular plan or payer is going to be compliant or not. And as sort of Ken mentioned, it's important to sort of keep documentation of all of this so we can bring it back to the legislator if it does appear that there are bad faith actors.
And to add on to that strategy as well, I think again, as pharmacists, we don't really do, well, some of us maybe, but I don't contract with the PBM. I have a managed care department. I have a legal team. I meet with them frequently. But one of the things we are starting to add in is language to be compliant with Florida rules and regulation. I'll just throw that out there. We're trying to put that in our health system contracts as a strategy, but something that folks can start thinking about as they approach their managed care departments. But I do think the bigger conversation is meeting with your managed care departments and meeting with your attorneys locally and talking about the specificities on a strategy.
I think that's a great point, Dave. Thank you for that. I had something else I was going to say. And don't let the PBMs bully you when you're talking to them. Know that this is the governor's bill. The reason this bill is so massive is because this is what the governor wanted. So let them know that you will certainly inform your legislators and the governor of any kind of bad feedback they give to you, and let us know too, and we'll report it up through our lobbyists. So don't let them bully you on this, because they have many bully tactics.
The monetary fines for non-compliance, it adds up. I mean, it's not in the section we talked about, but if you start looking through the other sections of this bill, there are some significant consequences for bad players in this space. As Kathy alluded to, keep the communication out there and make it very visible.
We have a question from our beloved Mike McGee. It says, great work, everyone. His mind goes to unintended consequences. The any willing provider nature of this. Is it possible patients will select chemo or other provider administered medications coordinated with the hospital from a pharmacy outside of the hospital? That's the first part of the question. Any thoughts on that?
So, I mean, white bagging in general puts hospitals in a bind, right? Because you're bypassing the hospital's safety procedures, you're requiring them to maintain a separate inventory. There's all kinds of patient safety considerations that's led a lot of hospitals to not try to accept white bag medications because of and brown bag medications because of the liability concerns. So, if a patient did insist on getting it from an outside pharmacy and the hospital or the infusion provider was not comfortable with that from a patient safety perspective, they could always decline to accept it from that from that particular means. Obviously, that's not an ideal scenario, but this is sort of a situation where you can have that conversation with a patient versus the current state where a payer can just say, this is how it is, you have no other options. It must come from an outside pharmacy.
And I guess I would add to that, this bill has really put the decision-making more in the patient's hands than in the insurance company's hands and the PBM's hands, that they have a choice of what they can do. But I think, Mike, to your point, I mean, hospitals have a choice too. If they're uncomfortable doing something that, for other reasons, maybe they would be against some of those policies for white bagging. You certainly can deny that. What it does is it removes the mandates that the insurance companies have right now and the PBMs have right now.
And I think that's key, Ken. What we really wanted and what we got was patient choice. So I've talked with directors and chief pharmacy officers of health systems throughout the state who rely on white bagging, and they want to do this. So they can, if that's what they want to do, if that's what's best for their patients, then they can do this, but it's no longer mandated. So that's what's the best of all worlds. So the second part of Mike's question is, can hospitals provide advantages for their employees who seek infusions at their health system? Example, no copay if done. Let me see if I can scroll down here. Mike, did I get your whole question or did I cut it off?
Yeah, the essence of this is that health systems also are providers and have health plans that they provide to their employees. And they also employ some of the same, I hate to say it, tactics that PBMs use as far as in-network discounts and those type of things, and out-of-network disincentives. And it seems to me like it's sort of in the same boat as what PBMs do. And I'm just, this is not to focus on the negative. I'm just trying to find out where the unintended consequences could be in this great work that Ken, Dave, Kathy, Kyle, and everybody else has done to get this legislation through.
So if I can to jump in on that one, so the way I understand the infrastructure, if your health system is funding your health plan for your organization, they really are in the driver's seat. Now, how they design their plan really depends on who they choose to be their PBM. because oftentimes they will. Now, I'm going to keep it at a very 80-foot level. You could go with one of the big PBMs like a CVS or an Optum, and a lot of providers do, and they're very influential in the way they want it managed. There's also another model. It's called a transparent PBM model, where you have more direct decisions and access to dollars and how to use those dollars. To answer your question, if you're in an organization that is self-funded, I would meet with whoever if you could, whoever the head executive is who's responsible for the plan. In my organization, it's an HR representative who kind of helps govern that process. This year, thank goodness, they brought me into the process to review and look at for optimization. I think getting pharmacy at a seat at that table will allow you to kind of look at it with different eyes and help your organization out with maybe even some of the offsetting of costs through, i.e. rebates or through managing. So again, what I would say is it comes into the understanding the framework of the structure. And usually that I've seen in most health systems, it's not a pharmacy person who's running that. It's usually in the HR area. And the key is, how do you connect with that person so they see the value of what you can explain to them? That's a long answer. I apologize, but I think understanding that framework and where to inject the recommendation is really what's going to change that process, or change maybe some sharing of copays.
Hey, Dave, that's great advice. The reason I ask is because I am that guy that's at that seat and trying to make those decisions for the health system. So good advice, though, that we need to be at the table.
And Mike, when we were getting educated on this, Ken, Dave, and I met with a couple of groups. One of them was Southern Scripts. They're a pharmacist-owned PBM. And they passed through, even prior to this legislation, all rebates back to the employer to reduce costs. And I'm aware of some health systems in this state. I'm not advertising for them. I'm just very grateful to Leanne, the owner, who educated us on a lot of the top 3 PBM bad behaviors. She really gave us insight into what they do. But she said, you really need to tell people that you're not stuck with those 3 PBMs that manage 80% of all of the prescriptions filled. There are legitimate PBMs out there. And she was one of them, Southern Scripts. So again, I'm not advertising for her. I have nothing to gain from this, but I'm very grateful to her for giving us the information that she did.
Thank you again for all your work.
Thank you.
And Michael, if you are sitting at that table, just a quick tip. I think if you're in that room, they make it very complicated. I think if you can unravel complicated to a simple single metric, cost per employee per day, or cost per script per day, to compare all of the 9 that are in the room, I would suggest that. And number 2, if you ensure that they have a portfolio of transparent model PBMs, plus the big ones, they're going to be in the room too. So you're looking at a single metric with enough people in the room that you can really compare the data. That would be my recommendation on just an if you are evaluating an apple, to get to apples. Because if you don't do that, I find it's always apples to oranges.
Well, thank you, everyone. We have 2 minutes left if anyone has any final questions. This recording will be made available to you if you want to share it with your hospital or health system lawyers. If they have any questions, they can contact us. And again, please keep us in the loop. We will feed back to the legislators through our lobbyists what your situations are. Darren, were you waving your hand at me or just at your computer? Okay.
Sorry, I was moving the camera. My apologies.
No worries. Okay. All right. I see no hands raised, nothing more in the chat. If you guys will double check me, I think we are good to go.
Yep, good to go.
All right, Mika, one last slide and tell us what we're selling here.
We are selling the best meeting in Florida. So if you have not registered, today is today that you get that $100 plus discount for registering for the FSHP 57th annual meeting. It will be epic. Don't hear about it. Be there to tell someone so that they can register next year. And Bill Kernan said the best meeting in the state. I concur. So I know that you guys will meet me there. Tell your colleagues 11:59. Have a
And
great evening.
where is it?
The Gaylord Palms Resort in Kissimmee, Florida.
And how much for a night?
164, hurry, because they are slim to none at this point, but we do have an overflow hotel, the World Center, which is not shabby either. So looking
Did you
forward to
get
it.
more rooms, Tamika? Did you get more budgeted rooms? Because I know when I tried to register, there weren't any available.
We do have some Wednesday through Friday right now.
Thank you.
You're welcome.
Thank you, Kyle from ASHP. We would nowhere be accomplishing what we're able to accomplish without your direction. I feel very educated because of you. So I thank you for that. And thank
Thanks,
you
Jen.
again, Dave and Ken. Good night, everyone.
Thank you guys. Good night.
Thank you, Mika.